Good morning everyone. We will be discussing neonatal tachyarrhythmias. I am Dr. Arushi. I am a senior resident in Division of Pediatrics. The outline of the presentation will be as follows. We will discuss the basic conduction physiology in a normal heart, followed by the basis of generation of a normal ECG, followed by the mechanisms underlying the common tachyarrhythmia seen in the neonatal age group, followed by the recognition of their ACGs, emergency management of the same, and fetal SVT management. So this is a pictorial representation of the normal conduction pathway of an anatomically normal heart. The impulse starts from the sinoatrial node, which is also known as the pacemaker of the heart, located in the right atrium. It then travels to the internodal pathway to the atrioventricular node. From the AV node, it travels to the bundle of His, which subsequently branches off to the bundle branches, right and left bundle branch, and then subsequently travels into the Purkinje fibers, which take the impulse throughout the ventricular musculature. This slide presents a very important point which is required for the understanding of normal as well as abnormal ECGs. So one important role of the AV node is that it delays impulse by about 0.1 second. This is a physiological delay which is very important to allow time for ventricular filling. The Purkinje fibers form a very rapid conduction pathway which is responsible for the impulse transmission throughout the ventricles. This allows for a coordinated ventricular contraction. This diagram shows the cardiac cycle, electrical cycle as well as the mechanical correlates. So as we can see, the depolarization starts from SA node in the right atria. This is followed by depolarization of the entire atrial musculature, which is seen on the ECG as a small positive deflection in lead 2 known as the P wave. Subsequently, the AV node gets depolarized and goes on to depolarize the entire ventricular septum through the bundle of His, which branches off into the right and left bundle and subsequently into the Purkinje fiber system, which depolarizes the entire ventricular musculature. The septal depolarization is seen as a small negative deflection in the lead 2 known as Q wave. Subsequently, the depolarization of the ventricles is represented by the QRS complex, and the depolarization of the ventricles is followed by repolarization, which is seen as T wave, and thus the electrical cycle of the heart is complete. Here we can see the normal ECG with the waves, intervals and the segments. So first we'll talk about the waves which are seen on a normal ECG and what they signify. So the P wave, which is seen as a positive deflection on the lead 2, signifies atrial depolarization. The QRS wave signifies the entire ventricular depolarization and the T wave signifies ventricular repolarization. Coming on to the intervals, so the PR interval, which starts from the beginning of P wave to the beginning of Q wave, signifies the duration taken for atrioventricular conduction. The QT interval, which is from the beginning of the Q wave to the end of T wave, signifies the entire ventricular action potential, which will include both depolarization and repolarization. The SC segment signifies the plateau portion of the ventricular action potential. The segments are basically these intervals without the wave included in them. So let's start by looking at an ECG. As we can see, the rate in this ECG is around 125 per minute. The rhythm seems to be regular. We can see that each QRS complex is preceded by a P wave. The P wave axis seems to be normal and the PR interval seems to be regular. So all these are peculiarities of a normal sinus rhythm. So this is a normal sinus ECG. After looking at this, we will subsequently move on to the arrhythmias. So broadly, all neonatal arrhythmias can be divided into either tachyarrhythmias or bradyarrhythmias. So the topic of discussion of this talk is tachycardias in the neonatal age group. We will first discuss sinus tachycardia and then move on to the abnormal rhythms, which will chiefly include supraventricular tachycardia and ventricular tachycardia. So as we have already discussed and also seen an ECG prior to this, a sinus tachycardia is characterized by P wave preceding each QRS complex. The P wave axis will be normal, which is 0 to 90 degrees in lead 2. The PR interval is regular. Now this may or may not be normal, but it will be regular. The rate is faster than the upper limit of normal for the age. So these are the characteristics of sinus tachycardia. So now let's move forward towards discussion of the neonatal abnormal rhythms, the neonatal tachyarrhythmias, which is the topic of discussion. So let's start with a case. So this is baby S born to gravida 4, para 2, abortion 1 and live 2 mother, born at a period of gestation of 33 weeks with a birth weight of 1436 grams. The baby cried immediately at birth. Initial steps were done. Apgar assigned at birth were 8 and 9. The baby subsequently developed tachycardia up to 260 beats per minute on day 8 of NICU stay. Now let's look at this ECG step by step. The first step here would be looking at the heart rate. So the heart rate, as we can see, is around 260 to 270 beats per minute. The rhythm seems to be fairly regular. If we look at the QRS complexes are narrow, and if we look for P-wave morphology, it is not discernible throughout the ECG strip. These are the characteristics of a SVT or a supraventricular tachycardia. So a supraventricular tachycardia is characterized by supraphysiological heart rate, rates more than 220 per minute in neonates and more than 240 per minute in preterm or the fetus. It is characterized by a abnormal P-wave morphology. The P-waves are usually invisible. Even when they are visible, they have either an abnormal axis and may precede or follow the QRS complex. There is no beat-to-beat variability and the QRS complex is characteristically narrow. We will discuss what is narrow and what is broad in the subsequent slides. So after seeing both sinus tachycardia and supraventricular tachycardia, let's compare and contrast both. So looking at the rate, a sinus rhythm is characterized by beat-to-beat variability. The heart rate is chiefly less than 220 in infants and less than 180 in children. Whereas in a SVT, there is no beat-to-beat variability and the heart rate is typically more than 220 in infants and more than 180 in older children. With respect to P waves, the P waves are present and are normal in a sinus rhythm, whereas they may be absent or abnormal in morphology in a SVT. The PR interval is of a normal and constant duration in a sinus rhythm, whereas in a SVT it is often short and might not even be discernible. The RR interval is often constant in an SVT, whereas it is variable in a sinus rhythm. QRS complex is narrow in both, less than 0.09 seconds. In SVT, it is less than 0.09 seconds in more than 90% of the cases. On the basis of mechanism of generation, SVTs are classified as either AV node dependent SVT or AV node independent SVT. For AV node dependent SVT, the mechanism of generation involves aberrant conduction involving the AV node. These are classified into AVRT, which is atrioventricular re-entry tachycardia, and AVNRT, which is AV nodal re-entry tachycardia. We will discuss these in details subsequently. The other category is AV node independent SVT, where the generation does not involve the AV node. These include atrial tachycardia, which is due to an ectopic foci, so known as ectopic atrial tachycardia or EAT, and atrial flutter. So this slide shows the two important mechanisms for generation of SVT. So one important mechanism is re-entry, which we will discuss subsequently. So arrhythmias generated due to re-entry include AVRT, AVNRT and atrial flutter. The other important mechanism is increased automaticity. This leads to arrhythmias including ectopic atrial tachycardia, junctional tachycardia and multifocal atrial tachycardia. Let's try to understand the re-entry mechanism through this simplistic diagrammatic representation. So here there are two distinct pathways that come together at the beginning and the end to form a loop. Now in the event of the pathways being normal, the electrical impulse will come down through the fast conduction pathway and then it will subsequently travel to depolarize the rest of the tissue downstream. Whereas now we will discuss what happens when there is a unidirectional block in one of the pathways. So this fast conduction pathway is characterized by a slow recovery, whereas the slow conduction pathway actually has a fast recovery period. So after a normal beat has gone down the pathway, what happens if there is a premature beat? So when there is a premature beat, as we know and we have already seen, the fast conduction pathway will be refractory owing to its slow recovery period. whereas the slow conduction pathway would have recovered by now because of its fast recovery pathway. So this abnormal premature beat will go down through the slow conduction pathway. The fast conduction pathway is blocked because of its long refractory period, so the beat can only go down the slow conduction pathway. So by the time the wave of excitation from the premature beat arrives at the distal end of the fast conducting pathway, the pathway would have recovered. So now the wave can travel retrograde backwards up the fast pathway. Then this retrograde traveling wave, by the time it arrives at the top of the fast pathway, the slow pathway would have already recovered because of its fast recovery. So the wave can now go down this pathway, and this continues in a circular movement. This is how a re-entry circuit is created, and this is the basis for a lot of arrhythmias, which we will discuss in the subsequent slides. Now that we have understood the mechanism of generation of re-entry circuit using a simplistic model, we can apply the same to understand AV node dependent SVTs. This includes two rhythms, AV-RT, which is atrioventricular re-entry tachycardia, and AV-NRT, which is AV nodal re-entry tachycardia. The difference here is that in AV-RT, the accessory pathway is located outside the AV node, whereas in AV-NRT, the accessory pathway is located within the AV node itself. So in AV-RT, there is one AV node and there is another accessory pathway which lies outside the AV node, and this mediates the tachycardia. In AV-NRT again, we have two pathways, one would be slow and one would be fast, but both exist within the AV node. Now both the pathways can have either orthodromic or antidromic conduction, depending on which we further subclassify AV-RT and AV-NRT. Let's look at a prototypical example, which is WPW syndrome or Wolff-Parkinson-White syndrome. After a normal sinus beat has gone down the AV nodal pathway, the AV nodal pathway will be refractory. So when a premature excitation beat is fired, it will go down through the accessory pathway, which would have recovered because of its short refractory period. Because this pre-excitation pathway is a fast pathway, it will start depolarizing the ventricles very fast. This is seen as evidence of pre-excitation, which is classically known as the delta wave. Because this is a fast pathway, we can understand that the PR interval will be short. But the impulse is traveling through the ventricles through a pathway which is different from the Purkinje pathways, which is actually a slow conduction, and therefore the QRS complex is a wide QRS complex. So this is how the rhythm in WPW syndrome is generated. Here we can see the ECG in Wolff-Parkinson-White syndrome, and we can see the findings that we have previously discussed, including presence of a delta wave, short PR interval and wide QRS interval. Now let's discuss the subtypes of AV-RT, the antidromic and orthodromic AV-RT. The nomenclature is on the basis of direction of impulse traveling through the AV node. So when the antegrade conduction is occurring through AV node, it is called orthodromic AV-RT. The generation of ECG here can be explained by antegrade conduction through AV node, wherein the impulse will travel and depolarize the ventricles through the normal physiological Purkinje pathways, which is the fastest conduction pathway. The QRS complex generated will therein be narrow. Then, when the retrograde conduction occurs through the bypass tract, it creates inverted P waves after the QRS complex with a short RP interval, because this is a fast conduction pathway. So this is a diagrammatic representation of the same. The normal wave goes down through the AV nodal pathway, goes and depolarizes the ventricles through a Purkinje fiber pathway leading to a narrow QRS complex. But by the time the wave is traveling retrograde, the AV nodal pathway will be refractory. So it goes down through the accessory pathway, which would not be refractory because of its short recovery period. And it goes and depolarizes the atria from below, therein leading to a negative P wave deflection. And because this is the fast pathway, the RP interval here would be short. So let's see with an example. Look at this ECG. Here we can see the rate is definitely more than 220 beats per minute. The RR interval is constant without any beat to beat variability. The QR complexes are narrow, less than 0.09 seconds. And the QRS complexes are followed by a negative deflection, a negative P wave with a short RP interval. So this is a AV-RT with the orthodromic conduction, a orthodromic AV-RT. Now let's come to antidromic AVRT. As we can understand through the name, in this type of SVT, the antegrade conduction occurs through the bypass tract and the retrograde conduction occurs through the AV node. So because antegrade conduction occurs through the bypass tract, we can understand that the ventricular depolarization will not occur through the Purkinje fiber pathway, which is the fast pathway. Therefore, the ventricular depolarization actually occurs slowly and leads to a wide QRS complex. Retrograde P waves precede the wide QRS complex with a short PR interval and a long RP interval. So this is actually one example of SVT with a broad QRS complex, which is AVRT with antidromic conduction. As antegrade conduction occurs through the bypass tract, it produces a wide QRS complex here. So subsequently we'll discuss the more commoner differential of a wide complex QRS, which is ventricular tachycardia. Let's move on to the second type, AV node re-entry tachycardia, AVNRT. Here also it is further subdivided into orthodromic and antidromic. Orthodromic is the slow fast pathway where the antegrade conduction occurs through the slow pathway and the retrograde occurs through the fast pathway. This also we can remember on the basis that in AVRT also the nomenclature is on the basis of direction of travel in the slow pathway, which is the AV node. Here also the nomenclature is through the direction of the impulse transmission in the slow pathway. So if the impulse is traveling anterograde in the slow limb, it is known as orthodromic, whereas if it is traveling retrograde in the slow limb, it is known as antidromic pathway. Let's discuss subsequently what happens in these rhythms. So in slow fast AVNRT, there is slow antegrade conduction and rapid retrograde conduction. This leads to a long PR interval because of slow antegrade conduction, and understandably because of rapid retrograde conduction, there is a short RP interval. Whereas in fast slow AVNRT, there is fast antegrade conduction and slow retrograde conduction. So because of fast antegrade conduction, there will be a short PR interval, and because of slow retrograde conduction, there will be inverted P waves after QRS with a long RP interval. Now let's move on to the other group of tachyarrhythmias, which is due to increased automaticity. So ectopic atrial tachycardia is characterized by a variable heart rate. The rhythm is being generated by a ectopic foci within the atria. So as the impulse goes down through the normal Purkinje pathway within the ventricles, the tachycardia is characterized by a narrow complex tachycardia with P waves being abnormal in morphology, which is understandable because they are not originating through the SA node and they are not going through the normal AV nodal pathway. There will be an abnormal P wave axis because of the abnormal origin of the P waves, and there is often a warm up and cool down phenomena which is seen with ectopic atrial tachycardia. So let's see the example. This again is a SVT and a narrow complex tachycardia because the QRS complexes here are narrow, and we can see that the P waves here are not discernible in either of the leads. So this is an example of a SVT, which could possibly be a ectopic atrial tachycardia. The next type is a multifocal, also known as chaotic atrial tachycardia. Here there are more than or equal to 3 ectopic waves because of presence of multiple ectopic foci within the atria. The P wave morphology and axis is variable, and the PR intervals will be varying here throughout. So let's see a prototypical ECG. Here we can see this again is a SVT. We can make that out on the basis that this is a narrow complex tachycardia without any beat to beat variability. If we start digging here for the P waves, we can see there are multiple variable morphologies of P waves. Somewhere P waves are inverted, some P waves are upright. Their PR interval is also variable throughout. So this is an example of a multifocal or a chaotic atrial tachycardia. Let's discuss another rhythm which is relatively rare, which originates within the AV node and an ectopic foci. So this is known as nodal ectopic tachycardia. This is a rare rhythm and it resembles atrial tachycardia. Here the P waves will be buried in the T wave of the preceding beat, and the rate is relatively slower, somewhere around 120 to 200 beats per minute. Now we have another case here. This is the case of baby S born to primigravida mother at 36 plus 3 weeks period of gestation. The baby weighed 2434 grams at birth. The baby was antenatally detected to have supraventricular tachycardia, for which the mother was started on tab sotalol and tab digoxin. In view of persistent fetal tachycardia, the mother was taken up for LSCS. The baby had tachycardia on day 1 of life. So if we look at this ECG, we can again see a narrow complex tachycardia, and we can see for every QRS complex there are 2 P waves. So this is atrial flutter with 2:1 conduction. We can also appreciate the classical sawtooth morphology of the P wave seen here. So this was an example of atrial flutter. It is a common rhythm in the fetus and in the newborn period. The mechanism here is re-entry within the atria, so an intra-atrial re-entry mechanism. The atrial rates here can be very high, up to 500 in the neonate. There is a variable degree of AV block which is seen. The clinical status of the baby here will depend on the degree of AV block. So if there is a high degree of AV block, the ventricles will actually not beat at a very high rate. So the patient might actually be asymptomatic because of the near normal ventricular rate and the cardiac output being preserved. However, if the ventricular rate is high, this can lead to hemodynamic compromise. Atrial flutter is one of the important causes of fetal hydrops as well. Now let's discuss another rhythm which is known as ventricular tachycardia. This rhythm is relatively rare in the neonate. It is defined as a series of 3 or more premature ventricular contractions with a heart rate of 120 to 200 beats per minute. The rhythm originates within the ventricles, and the depolarization of ventricles does not occur through the normal Purkinje pathway. Therefore, the QRS complexes seen here are abnormally wide and bizarrely shaped. Let's look at this ECG strip. The heart rate here is around 220 beats per minute. The QRS complexes are wider than 0.09 seconds, and the QRS complexes are also abnormally shaped and they are wide and bizarre. So this is an example of a ventricular tachycardia. This is a very informative slide which sums up the causes of broad QRS. So in WPW syndrome, as we have already discussed, because of the presence of the delta wave due to pre-excitation, it can appear as if the QRS complexes are broad. Other most important differential is ventricular tachycardia. The third differential is bundle branch block, which can also lead to broad QRS complexes. So now that we have discussed about most of the common causes of broad complex tachycardia, let's summarize. So most importantly, ventricular tachycardia. Second, we discussed a subtype of AVRT, which is antidromic AVRT, which can actually present as a broad QRS tachycardia. And third is presence of SVT with a concomitant bundle branch block, where again we can get broad complex tachycardia because of the bundle branch block. Having said all of that, the dictum and the take-home message from this would be broad complex tachycardia is VT unless proven otherwise. So this slide describes the characteristics of ventricular tachycardia. There is dissociation between atrial and ventricular activity. Whilst the ventricular rhythm is ongoing, a normal sinus rhythm originating within the sinus node and traveling through the normal Purkinje pathway within the ventricles, hence producing a narrow QRS complex, can get captured in between these broad and bizarrely shaped QRS complexes, which is known as a capture beat and is pathognomic of a VT. There can also be presence of fusion beats, which are also characteristically seen in a VT. So now that we have described every type of arrhythmia individually and we have understood the basis of generation, let's sum it all up and understand the approach to neonatal tachycardias and how to interpret an ECG that we are provided with. The first step, once you have picked up neonatal tachycardia, is to look at the QRS width, whether it is narrow or whether it is wide. Within wide QRS tachycardia, the next important thing to look at is the P wave to QRS wave ratio. So if this is less than 1:1, which essentially means that for every QRS complex there is less than 1 P wave, it is characteristic of ventricular tachycardia. Whereas if the ratio is 1:1, that is every QRS complex is preceded by a P wave, the differential here could either be a SVT with the presence of an ongoing bundle branch block, and another example will be an SVT which we had described and we had understood how it leads to a wide QRS, is the antidromic type of AVRT. Now let's come to narrow complex tachycardia. Here again we look at the P is to QRS ratio. If it is 1:1 and the P wave is not visible, it could be a AV-NRT. If there is short RP interval and P wave follows QRS, it could be AV-RT. If there is a very long RP interval, it could be a ectopic atrial tachycardia or a permanent junctional reciprocating tachycardia, which is a very potentially lethal rhythm. If the ratio is more than 1:1, that is, there are more number of P waves with a regular rate, it is atrial flutter. If the atrial rate is variable, it could be ectopic atrial tachycardia. And if the chaotic atrial rate is present, it could be MAT or atrial fibrillation. If the P to QRS ratio is less than 1:1, it could be junctional ectopic tachycardia. Now let's move on to the more practical aspect, which is management. So the first step in the management is identifying the rhythm correctly. Once we have identified the rhythm, we have to identify the presence or absence of circulatory collapse. Circulatory collapse with tachycardia requires management with immediate synchronized DC cardioversion. It is administered as 0.5 to 1 joules per kg and the repeat shock can be given up to 2 joules per kg. Whereas, if there is narrow complex tachycardia without hemodynamic compromise, it can be managed with either vagal maneuvers or drugs. And the drug of choice here is adenosine. So the SVT management is again dictated by the mechanism of generation of the arrhythmias. Arrhythmias which are based on AV node and which are AV node dependent SVTs are easier to treat and usually occur in a paroxysmal manner. Whereas AV node independent arrhythmias are harder to treat and AV node blocking drugs usually do not help. They may need other class of antiarrhythmic drugs like flecainide, amiodarone, sotalol, which actually have a pro-arrhythmogenic potential and therefore are more dangerous to use. These can be incessant and lead to hemodynamic compromise, compromised cardiac filling, and ultimately to heart failure. Let's discuss about the most important drug, which is adenosine. The mechanism of action is that it slows down AV conduction. Therefore, it is helpful only in AV node dependent SVTs. The initial dose to be administered is 0.1 mg per kg, a maximum of 6 mg, and it has to be administered rapidly intravenously into a large vein which is as close to the heart as possible. The repeat dose is 0.2 mg per kg, maximum of 12 mg. Failure to respond to adenosine may be due to inadequate dosage or too slow administration. Other important differential to be kept in mind is a AV node independent SVT or a VT. We can see this ECG strip and we can see prior to administration of adenosine, a fast rhythm with a narrow QRS complex is present. We diagnose SVT and administer adenosine and the rhythm has beautifully resolved and it has become a sinus rhythm again. This algorithm shows how response to IV adenosine can give diagnostic clues. If there is no change in rate, it could be because of inadequate dose or too slow delivery of adenosine. It can also occur in ventricular tachycardias, specifically fascicular or high septal origin VTs are more likely to be confused. If there is gradual slowing and then re-acceleration of rate, it could signify a sinus tachycardia, a atrial tachycardia, or a non-paroxysmal junctional tachycardia. Sudden termination of the rhythm and reversal to sinus rhythm occurs in AVRT or AVNRT. If there is persistent atrial tachycardia with only a transient AV block, it could be seen in atrial tachycardias like atrial flutter or ectopic atrial tachycardias. Now let's discuss the maintenance therapy for SVT once we have reverted the rhythm using adenosine or DC cardioversion. So the first line is beta blockers which inhibit sinus node and AV node conduction. Some of the agents available are IV esmolol, propranolol and atenolol. Second line drugs include flecainide, which is a sodium channel blocker with a risk of proarrhythmia and widening QRS complexes. Sotalol has a potassium channel blocking and a beta blocker effect. It can lead to QTC prolongation and proarrhythmia. The third agent available is amiodarone, which has potassium channel blocking along with multiple other actions. It is a potent drug with a long half-life. However, the side effects include photosensitivity, thyroid dysfunction, pulmonary fibrosis, and elevation of liver enzymes. Now let's discuss ventricular tachycardia management. In the acute state, it can be managed either with drugs like lidocaine and amiodarone or DC shock depending on hemodynamic status of the baby. Chronic management is either with drugs like amiodarone and sotalol, catheter ablation, which is less successful than SVTs, or defibrillator placement in selected cases. Briefly about synchronized cardioversion. What are the indications? the first and foremost most important indication to understand is cardiovascular compromise. The second indication would be where pharmacological management fails. Mechanism. So synchronized cardiofunction momentarily depolarizes all the cardiac cells and thus it interrupts the self-perpetuating re-entry circuits and restores the rhythm back to sinus. It is less effective in arrhythmias which occur due to increased automaticity. Let's try to understand the difference between defibrillation and cardioversion. So defibrillation is unsynchronized and cardioversion is synchronized on R waves. Defibrillation is used in peri-arrest cases, mostly in the emergency setup, whereas cardioversion could be either elective or emergency. Indications for defibrillation are very clearly defined and include pulseless ventricular tachycardia or a ventricular fibrillation. Cardioversion is indicated in atrial fibrillation, SVT or VT in shock or where there is failure of medical management. Defibrillation requires higher doses and cardioversion requires lower doses of energy joules. So this ECG strip shows how prior to synchronized cardioversion, the shock is administered in synchronization with the R waves. R waves have been marked here with these small arrows and this is where the shock will be administered in synchronization with the R waves. A brief word on fetal supraventricular tachycardias. This is the most common symptomatic fetal cardiac arrhythmias. AVRT is the most common mechanism and heart rates are typically in the range of 240 to 260 beats per minute. Fetuses with atrial flutter can have atrial rates up to 300 to 500 beats per minute with variable ventricular rates. Diagnostic modalities include USG and fetal echo. Structural malformations of the heart are seen in up to 5% of the cases. The most frequent structural malformations include Epstein anomaly of the tricuspid valve, AV canal defect, hypoplastic left heart syndrome, or a cardiac rhabdomyoma. The goals of therapy include restoration of sinus rhythm, rate control, resolving symptoms of heart failure, and postponement of delivery till term. Treatment indications include prematurity and severe hemodynamic compromise including hydrops. Digoxin is the first-line drug and others include amiodarone, flecainide and sotalol. So the points to remember would be identification of a normal sinus rhythm, SVT mechanisms, broadly re-entry and increased automaticity. Orthodromic AVRT is the most common mechanism of neonatal SVT. How to differentiate between narrow and broad complex QRS on an ECG. Broad complex tachycardia is VT unless proven otherwise. If hemodynamic compromise, give synchronized cardioversion. Adenosine is the first choice in all AV node dependent SVTs. Thank you.